Hi everyone, in this video I'm going to discuss about intra-aortic balloon pump or IABP. I'm Julian Thomas, faculty working in Tripoli College of Nursing. The objectives of this discussion includes the group should be able to define IABP, brief the principle of IABP machine, enlist the purpose of IABP, enumerate the indications and contraindications of IABP, describe the setup of IABP, brief the nursing care of patients with IABP. The few terminologies in relations to IABP includes first one is preload. Preload is a measure of the degree of the ventricular stretch when the heart is at the end of the diastole. It is also called left ventricular end diastolic pressure or LVEDP. Afterload, it is the amount of resistance the heart must overcome to open the aortic valve and push the blood volume out into the systemic circulation. It is also called systemic vascular resistance or SVR. Systole, the phase of the heartbeat during which the cardiac muscle contracts actively ejecting blood through the open aortic valve. Diastole is the phase of the heartbeat during which the left ventricle fills with blood from the left atrium through the open mitral valve and during which majority of the coronary perfusions occurs. Counter pulsation, it is the rhythmic mechanical pumping which is synchronized with the heartbeat. Intra-aortic balloon pump. It is also known as IABP. The intra-aortic balloon pump system is a volume displacement device. So the intra-aortic balloon pump, otherwise known as IABP, is a mechanical device that increases the myocardial perfusion and indirectly increases cardiac output through afterload reduction. So it is also known as intra-aortic counter pulsation device. The main mechanism with this intra-aortic balloon pump which increases the blood circulation to the coronary arteries. IABP catheters. So this IABP catheter, it consists of a cylindrical polyurethane balloon that always sits in the aorta. It's approximately 2 centimeters or 0.79 inches from the left subclavian artery. It should be always positioned so that the tip is approximately 1 to 2 centimeter below the origin of left subclavian artery and it should be always above the renal arteries. It should not obstruct the renal arteries. So on chest X-ray, we can see the tip of the catheter is visible in the second and the third intercostal space. So the balloon inflates and deflates via counter pulsation, which means the balloon actively deflates in the systole and inflates in the diastole. So when the systole happens, adequate amount of blood will be pumped into the systemic circulation because the balloon is deflated, and in diastole what will happen, it will be inflated so that more amount of blood will be gone into the myocardial arteries. So by this mechanism, in IABP, systolic deflation decreases afterload through a vacuum effect and indirectly increases forward flow of blood from heart into the systemic circulation. The diastolic inflation increases blood flow to the coronary arteries via retrograde flow. So these actions combine to decrease myocardial oxygen demand and it increases the myocardial oxygen supply. IABP machine. So this IABP machine is a computer controlled mechanism which inflates the balloon with a helium gas from a cylinder during diastole. Usually it is linked to either an electrocardiogram ECG or a pressure transducer at the tip of the catheter. In some IABP such as Datascope System 98XT, which allows an asynchronous counter pulsation at a set rate, though the setting is rarely used. So helium is the gas which is used to inflate the balloon. Why? Because of its low density means there is a little turbulent flow so the balloon can inflate quickly and deflate slowly. It is also relatively benign and eliminated quickly if there is a leak or rupture in the balloon. So that is the reason why helium gas is used in IABP machine. So this is the setup of an IABP machine. Here we have a controller unit. So here we can see the ECG wave changes and the IABP waveforms. So this rapidly inflates the intra-aortic balloon just after an aortic valve closure. So this will be connected to a pressure transducer and pressure bag used to measure the pressure within the aorta. Some newer IABP system uses a fiber optic sensor to measure pressure changes more rapidly. On the down of this machine, we can see the helium tank. Helium is used because it has lower airflow resistance, which enables faster balloon inflation and deflation. Helium is also highly soluble in blood, so it is less likely to cause any air embolism. The components of this IABP machines include it has a monitoring system, that is the machine can display the patient's ECG and the arterial waveforms, and it has an electronic trigger mechanism, that is R wave. Every R wave only there will be inflation and deflation takes place. Then it has a drive system, that is the drive system that drives gas in and out of the balloon is alternating with the pressure and the vacuum. Insertion technique. This IABP can be inserted in two methods, that is percutaneous, this is a sheathless method, and is a surgical insertion. Direct femoral cut down can be done, or transthoracic way this catheter can be inserted. So either percutaneous or surgical insertion, the catheter will be inserted into the femoral artery. So through the femoral artery it will be forwarded and the tip will go and sit in the aorta. So the radio opaque tip should be 2 centimeter distal to the left subclavian artery. So this is the balloon where a 20 to 50 ml of aortic balloon fills 85 to 90% of the thoracic aorta. So the balloon should be proximal to the renal artery. It should not obstruct the renal arteries. So the size of the catheter will be 7.5 French, and the sheath is placed in artery and allows balloon catheter to be advanced into the aorta. So the sterile sleeve permits adjusting the depth of the intra-aortic balloon if it is needed. So the principle behind IABP, intra-aortic balloon pump. A catheter is placed through the arterial sheath and advanced into the thoracic aorta. So it will stay in the aorta next proximal to the subclavian artery. So a gas-filled balloon at the tip of the catheter which inflates in synchronize with the cardiac cycle. So the balloon inflates when the diastole happens, so there will be increases coronary perfusion, and the balloon deflates in the systole which decreases the afterload and increases the left ventricular stroke volume. So from this picture it is clear that during the systole the balloon will deflate so that more amount of blood will go into the systemic circulation. So it decreases the afterload and increases the cardiac output. So in diastole what will happen, the balloon will be inflated so that more amount will go into the myocardial artery. So it increases the diastolic blood pressure and increases the coronary perfusion. Purpose of IABP. The IABP is commonly used for patients when they need hemodynamic support in medical conditions, prophylactic hemodynamic support, cardiac support for hemodynamically challenged patients with mechanical defects prior to correction. The balloon is inflated during diastole to increase coronary perfusion and then deflated during systole to decrease the afterload. So this aims to improve myocardial oxygenation, increases cardiac output and organ perfusions with a reduction in left ventricular workload. Indications and contraindications of IABP. The indications for IABP includes in case of acute myocardial infarction, cardiogenic shock, left ventricular failure, low cardiac output, post-myocardial ventricular irritability, any cardiac thoracic surgery. Intra-aortic balloon pump have also been inserted as a last-ditch measure to stop hemorrhage from the aorta or its branches when aorta bleeds heavily or when patient have a massive GI hemorrhage. And the contraindications of IABP includes the absolute contraindications include aortic valve insufficiency if the aorta is not functioning properly or dissecting aortic aneurysm. And the relative contraindications include end-stage cardiomyopathies, severe atherosclerosis, end-stage terminal disease, abdominal aortic aneurysm, blood dyskaryosis, and thrombocytopenia. For an for inserting an IABP, we require an IABP kit. The contents of the kit include an introducer needle, guide wire, vessel dilators, sheath, IABP 30 or 40 cc syringe, gas tubing, 60 ml syringe, three-way stopcock, arterial pressure tubing. It is not there in the kit. Additionally, we need to keep it. Confirmation of position. So after inserting IABP catheter, how to confirm the position of the catheter, whether it is in the aorta or not. So arterial balloon waveforms and pressures are shown on the console or on the machine monitor. So check for normal morphology and appropriate timing of inflation and deflation, that is 1:2 augmentation ratio. Chest X-ray or fluoroscopy. Confirm radio opaque tip lies in the second intercostal space just above the left main bronchus. The lower end of the balloon should lie cephal to the renal arteries. Then transesophageal echo is another method of confirming the position. Direct visualization 1 centimeter distal to the left subclavian artery can confirm the position of the IABP catheter. Triggering and timing. So triggering and timing is an important factor in IABP. So when how to set the timings in an IABP and when the machine has to give the trigger. So the balloon is timed to inflate and deflate in time with the cardiac cycle. So the trigger options include either the trigger can be done based on the ECG, that is ECG using the R wave to identify the onset of systole. If the patient is having a sinus rhythm, then deflation can be done for a set time period. But in case of atrial fibrillation, the balloon deflates when R waves are sensed. If paced, then pacing spikes can be used to detect the cardiac cycle events. And arterial waveforms can also be used for triggering using the arterial upslope to designate the systole. An internal trigger mode is available in the machine for asystolic arrested patients. Trigger. In order to synchronize the balloon with the cardiac cycles, the controller uses ECG or aortic pressure to trigger the inflation. So asynchronous example to set at a rate of 80 can be used as a backup. So ECG can be used as a triggering factor that triggers inflation at the middle of the T wave and that triggers deflation at the peak of the R wave. So arrhythmias such as afibrillation and the pacer spikes can disrupt ECG triggering. So atrial pacing is particularly problematic in such kinds of patients. So ECG triggering is preferable in most patients. Pressure. Aortic pressure triggers inflation as the dicrotic notch and deflates based elapsed time. So pressure trigger is inherently less precise than electrocardiogram. So the pressure waves propagate slower than the electricity. Timing. So ideally when the balloon should actually inflate and deflate. What is the set timing? So ideally balloon will inflate immediately at the onset of diastole, that is 40 millisecond before the dicrotic notch appear in the ECG waveform. So what are some of the consequences of improper timing? So which includes early balloon inflation. So that will leads to increased afterload. Late balloon inflation which can leads to decreased diastolic augmentation. Early balloon deflation, no decrease in myocardial oxygen demand. So late balloon deflation, again it increases the afterload, and poor diastolic augmentation which leads to suboptimal coronary perfusion. So timing should always be adjusted to 1:2 support. The efficiency of the IABP machines can be affected by certain factors, so which include the timing of inflation and deflation, the assist ratio, what ratios we have kept for 1:2 or 1:4 or 1:8. So what is the ratio we have kept, and the heart rate if the patient is having tachycardia more than 130 per minute, which reduces the benefit of IABP, and gas loss from the balloon. So these are some of the factors which can affect the efficiency of IABP. So when the patient is on IABP, what what we need to monitor from the patient. So always we should monitor for limb ischemia because it is from the femoral artery, so the circulation to the lower extremities can be affected. So always check for ischemia in the limb. So we need to monitor the distal pulses constantly. Then we need to monitor for juxta-renal positioning, whether the catheter is positioned in the renal artery. So it can obstruct the renal artery and the renal functions can be impaired. So always we should monitor the urine output and chest X-ray of the patient, whether the catheter is in the correct position or not. Then another factor which we need to monitor is bleeding or hematoma. So in order to monitor bleeding or hematoma because of IABP, we need to monitor the sheath site and check the coagulation factors. Decreased augmentation is another factor. So, in order to monitor this decreased augmentation, we need to consider low systemic vascular resistance in case of sepsis and decreased cardiac output and AIBP, arterial blood pressure requires a index of more than 1 to augment. And worsening of cardiac ischemia, adjust the timing or the trigger. Assessment and monitoring of IABP patients. So always we should monitor and document systolic, diastolic, mean arterial pressure and diastolic augmentation pressure from the IABP console hourly, and it should be written in the nurse's chart. Use mean arterial pressure on IABP to titrate the drips which is going for the patient. Then print the ECG strips from the IABP and mount on the back of the flow sheet every 12th hourly and auscultate the heart and breath sounds while the IABP is on standby. So limit the amount of the time the pump is placed on standby, especially for patients with unstable BP or active ischemia. We should not keep the machine on standby for a long period. Never allow the pump to be paused for more than 30 minutes. Ensure that the standby advisory tone is on. So monitor the pedal and radial pulses on the affected side every 15 minutes for 1 hour and then every hourly. So if balloon moves up or down, it could occlude the perfusion to those limbs. So monitor for signs of limb ischemia. The signs of limb ischemia include changes in color, sensation, temperature, movement, and capillary refill. So we need to monitor for the color, sensation, temperature, movement, and capillary refill in the lower extremities every 15 minutes for 1 hour and then hourly. Monitor urine output closely. If balloon migrates down, it can obstruct the renal arteries, so the renal function will be impaired. So notify provider or the physician if the urine output is less than 0.5 ml per kg per hour. And assess the insertion site for any bleeding, hematoma and signs of infection hourly. Assess tubing for any signs of blood or leak hourly, helium leak hourly. So ensure a chest X-ray is ordered and review to confirm the placement of the catheter. So a chest X-ray should be obtained every 24 hours and whenever needed to check for the malposition of the catheter. When the IABP machine or catheter is in position, we need to watch for signs of a dissecting aortic aneurysm. Use strict aseptic technique when redressing or manipulating the line. Notify medical team for any changes on assessment or monitoring immediately. Keep affected leg in an extension. Do not raise head of bed beyond 45 degree. If the moving or non-compliant patient may displace the IABP. So always we need to have the patient lie down in a supine position with the leg extended. Never leave the balloon pump on standby. So more than 30 minutes. So, assess in the assessment and monitoring, the initial assessment of the patient immediately after inserting an IABP, what we need to assess from the patient. A chest X-ray immediately should be taken to check the position of the catheter. Inspect the insertion site. Assess peripheral pulse for 4 limbs every 15 minutes for 1 hour. First 1 hour and every 13 minutes on the second hour and then hourly. Then assess the lower extremities or lower limbs for the color, temperature and the capillary refill time and place a saturation probe on the left hand. So this is the initial immediate assessment for the patient. An initial assessment for the device or the IABP machine includes check arterial waveform and ECG trace, check adequate trigger, timing, frequency and ratio is set with the medical team. Check the console alarms, IABP lines, pressure bag and the helium tank whether it is functioning properly. And then anticoagulation for IABP is not required. So, and also it based on the hospital policies and it varies with the consultants. So, in assessment and monitoring, after immediate care, in the regular monitoring of the patient, we should include hourly monitor BP, augmented pressure, and the urine output of the patient. Hourly, we should assess both pedal and the radial pulses and the insertion site. And daily, we should take an ECG and it should be attached to the flow chart and the coagulation study should be conducted. And regular monitoring of the device includes daily we should check or hourly check for arterial trace, ECG triggers, timing, frequency and the ratio set, a regular check of the pressure bag, IABP lines and the helium tank. IABP care. The IABP care includes set the augmentation alarm 10 mm Hg below the augmented diastolic pressure. The alarm should be on continuously and on maximum volume. Inspect the pressure bag for volume and proper inflation. Always use 0.9% NS, never heparin. So change the flush bag every third day and transduce the aortic arterial line via datascope console and check the helium tank level by checking the gauge on the side of the console and replace the tank as needed. While changing the helium tank, leave the console on and running. Ensure that the helium gauge shows a full tank. Never power flush or draw blood from IABP arterial line. That is an important thing we should remember. Never push flush or draw blood from IABP arterial line. If this is absolutely necessary, obtain an order from the healthcare provider and always place the pump on standby while blood is drawn and the line is flushed. Never let povidone iodine solutions to come in contact with the catheter. Label the IABP tubing at the insertion site as a reference point for catheter migration. So any dislodgement can be easily identified with this. And IABP frequency to be maintained by the physician order. So if IABP timing is 1 is to 2 or 1 is to 3, the patient should be receiving systemic anticoagulation. Wean IABP as per the doctor's order. So before weaning, we should place IABP on 1 is to 2 and 1 is to 3 prior to discontinuing to ensure patient tolerance. If the patient is tolerating, then place the trigger on 1 is to 1 and then turn off the anticoagulation before IABP is pulled. If the IABP is discontinued, clean the pump, bring it out of the room and plug in. So weaning of IABP, when we can remove the IABP. So we should keep consider that weaning should only be attempted on the order of a physician. Without the physician's order, we should not remove the IABP. So when we can plan for a weaning, the patient should be stable for 24 to 48 hours, decreasing the inotropic support, decreasing the pump ratio from 1 is to 1, 1 is to 2 or 1 is to 3, decrease the augmentation, monitor the patient closely. If the patient becomes unstable, weaning should be immediately discontinued. Removal of IABP. So always keep it in mind IABP should be pulled by a physician or it should be removed by a physician. So preparation. So removal should be performed by a competent and suitably trained person. If anticoagulant for IABP is used, stop 1 to 4 hours before the removal. Check the clotting factors. If abnormal, discuss with the medical team before removing or before proceeding. So press the standby on IABP. Disconnect the IABP catheter from the IABP pump with aseptic techniques, remove dressing and sutures. So after removing the sutures, we should reflate the balloon, apply manual pressure above and below the IABP insertion site, remove and alternate pressure to expel any clots, apply constant pressure to the insertion site for minimum of 30 minutes to prevent bleeding and check the distal pulses frequently. So in removal of IABP, we should consider if sheath or sheathless. So insertion sheath in place, loosen the sheath seal from the hub with a twist. Pull just the catheter and stop once the resistance is felt. Then apply pressure just above the insertion site. Remove insertion sheath and IABP catheter as a single unit. Do not try to pull the IABP catheter through the sheath. So togetherly we should remove it. If it is a sheathless, apply pressure just below the insertion site, remove the IABP. If any unexpected or excessive resistance we found, stop removal and seek the expert intervention. So after removal of the device, Firm pressure should be applied on the site to prevent the bleeding. So apply pressure to the puncture site for 30 minutes with compressive dressing or femostop. Maintain patient in supine position with affected leg extended for 6 to 8 hours. Patient should be in supine position with the leg extended. They should not flex the affected leg. Perform hourly check of pedal pulse, color and temperature of both legs until 24 hours post removal of the device. Documentation. So after once this device has been removed, in the invasive line section, document the location of the IABP, document the mode, frequency, trigger, pulses, site assessment, and the tubing assessment with that the nurse has been done hourly. If there is any significant findings during the circulation assessment, document a description of the assessment and who was made aware of the findings, to whom the nurse has been informed the findings. That should also be marked in the documentation sheet. Complications. So the common complications associated with IABP include, so the people those who are at risk for developing complications are female, diabetic patients, smokers, obese patients, and patients with peripheral vascular disease, hypertension, and high systemic vascular resistance or shock. So these are the patients who are at risk for developing complications in IABP. So the common complications include, the first one is limb ischemia. In such cases, we can identify absent peripheral pulses, coolness and discoloration in the lower extremity. Balloon misplacement or migration is another complication. In this, there will be absent left upper limb pulse, urine output less than 0.5 ml per kg per hour, and the presence of blood in urine. Then gas or clot embolus, console the alarm will ring, then sudden patient instability will be there. Treatment of an air embolism is as follows. So 100% oxygen we need to give to the patient, intubate the patient suddenly, and we need to give a Trendelenburg in left lateral decubit positions, and fluid resuscitation should be done in case of any air embolism. And other complications include balloon leak, blood or brown flecks or lines can be seen on the IABP lines, and the alarm will ring. And the bleeding from the insertion site, remove the dressing, put on sterile gloves, and we need to apply pressure for 30 minutes to arrest the bleeding. In case of infection, check the catheter insertion site often. Strict aseptic technique should be followed. Restrict the movement while IABP in place. So always ask the patient to be in supine with the affected leg extended. So aortic wall dissection or rupture or local vascular injury is another complications associated with this IABP. So coffee grounds can be seen in the drive line. It is a precursor to a rupture. So make sure they are on inside and not outside of the tubing. So notify the physician immediately. If there is a flagrant rupture of the IABP, immediately we need to clamp the gas line. So we need to inform the physician or the healthcare provider if there is a blood in tubing or any vascular changes, that is a diminished pulses in the lower extremity or low signals, and augmentation pressure if it is less than 5 mmHg or above systolic BP, bleeding or hematoma at the insertion site, or any signs of retroperitoneal bleed, drop in hematocrit unexplained by other bleeding sites, an abrupt stop in urinary output, or any signs of dissecting aorta, sudden or recurrent chest pain, or any back pain, or any discrepancy of the upper extremity blood pressure, we need to inform the healthcare professional immediately. So to conclude IABP, the interprofessional team should closely monitor vital signs to ensure adequate augmentation with IABP. Frequent neurological exam should be done to monitor for cerebrovascular complication, stroke, and to monitor for delirium is needed. The IABP of nowadays is a mechanical support device which is still used safely and widely in treatment of low cardiac output developing after cardiac surgery. The easiness of the implementation of this mechanical support is the main reason, that is, it is the first preference in all kinds of intensive care units and open heart surgery. Thank you.